peritoneal and hemodialysis. Again, depends what the doctor needs, kind of patients they have. They have to choose which one the patient would need the dialysis, okay? But both method can be used. And abdominal, when you're doing peritoneal, patient can do their home, and they can be home. Mostly your questions are going to be on teaching. Remember, it's very important that you remember the word hyperglycemia and dwell time, okay? And peritonitis word is important. Cloudy color is important. Next is kidney transplant. Now dialysis is done and patient may be qualified for kidney transplant. But what is the recipient would get? Underline the word immune suppressive medication. Immune system to keep there, and they have to take their life. Patient is scheduled for renal transplant. What do you teach them? That make sure patient knows they have to take all their life immune suppressive medication. Next is living donor is the best, is to give them. Always you check the blood grouping. Histopathology or histocompatibility means that tissue they're matching. No communicable disease, and patient is in excellent health, those who are giving. So living donor is the best, but you got to see proper match, and those are the things. Cadaver means someone who's going to donate, and cadaver is criteria. What is cadaver means? Criteria of death should be there, the brain death. Age, under 70 years of age, and kidneys are normally functioning. Third line is important. Before, when you're taking it out, make sure patient has cerebral death, that means the brain has been established, but restoration is important, and volume of the fluid intravascular, weaning from vasopressor. Diuresis is a good word, continuous ventilation, and keeping the heart rate maintained until the kidneys are removed. So number one, in cadaver, age is important, under 70 years. Cerebral death has to be established. Another word, they can use the word diuresis and ventilator. That means they continue to keep patient hydrate and maintain their blood pressure, and by maintaining the ventilating ventilator until they remove the kidney. You want to hydrate the patient. Next is recipient. Recipient person who is admitted for renal transplant. What kind of isolation you will keep that patient? Underline the word protective and write down the word reverse isolation. So before patient is going, where does pre-op? Reverse isolation. And same afterwards. Everyone remember, your questions are going to be, NCLEX is a lot of isolation. Your patient is going for renal transplant or came back, remember, reverse isolation. Hemodialysis. How long do you give dialysis? Underline 24 hours before. Before patient is going, must get the dialysis before they're going for surgery. Next is post-op care. What do you do in post-op is, number one, urine output begins immediately if the donor was living. If it is cadaver, that means it will take a longer time to establish urine output. So kidneys start functioning quicker if you're giving from living donor. That means the family member. If somebody cadaver means you're taking person who's donating when they're dying. It takes a little longer time. Number two, hemodialysis should be continued and patients until, how long patient need to be on dialysis after they have kidneys are transplanted, until the kidney established normally, and normal urine output should be 100 ml. Everyone is okay. So number two, how long do you continue hemodialysis? Until the kidneys start functioning normal. That means you continue. Before patient is going, you give them dialysis. What do you monitor daily? Weight. Write down weight gain, sign off, rejection. So if there is a question, patient gain 3 pounds, 2 pounds, that means patient's kidneys are affected. That means rejection. Rejection means kidneys are not functioning. Next is number 4. Position would be okay to semi-Fowler's position. And also you can go for is and promote the gas exchange and turn them on the back and non-affected or non-operative side. Semi-Fowler's is good. Pink color is normal for several days. Number 5, pink is normal. And gradually it will turn to normal. But number 6, if they have gross hematuria, that means the patient is bleeding. Protective isolation is important. Number 7 is diet, is as the doctor ordered. And when, before you give, check the bowel sounds or peristalsis. Ambulation is good after 24 hours. Avoid sitting too long. Why? Because it causes the pressure. Assess for rejection. The meaning is kidneys are not taking yet. So rejection means are sign of, write down weight gain, fever, and maybe they're using the word edema, BUN and creatinine is high, or edema and swelling. So what are the signs of rejection? Fever, you have, and weight gain. You have swelling, BUN and creatinine. And assess for their medication. What medication you will give them? Immune suppressive medication. I'll write down that some of them are cyclosporine, cyclosporine. One of them is your medication. Prograf, Prograf. Imuran, Imuran. Cellcept, that's your immune medication. Is on this one, cyclosporine, avoid grapefruit juice. Sometimes some of the drugs you cannot give them grapefruit juice. So write down on cyclosporine. And also, is you are avoiding that, and some of the medications, I wrote it down. Cyclosporine, Prograf, Imuran, Cellcept. Those are some of your medication. You can use them for patient for rejection or immune system. Is when you're giving Prograf, I think I want you to add there, check for blood sugar, it goes high. And also potassium and hypertension. Side effect, increased potassium, increased hypertension, and is the blood sugar. So just add there few things. Cellcept is also cyclosporine. We already wrote it down, for that is the grapefruit juice. So these are some of the drugs you will use it. Now I will move on. UTI question. UTI prevention is very important, and they use the word cystitis. Remember, whenever we are talking about UTI, there are two kinds of UTI, lower part of UTI and upper UTI. Some question they say you lower. Lower means is the bladder. Where does we start the infection in the bladder? From urethra. And which is the common in female, because a urethra is smaller than the male. So female are more risk for getting UTI. Are we clear? Where do we start the UTI? From the bladder. And the first is the urethra. And that's why cleaning is very important. And remember, the word cleaning front to back is important. So cystitis is soap, spray, bubble bath, sanitary napkins, indwelling catheter, sexual intercourse, urinary stasis, wet bathing suit, sitting for too long can lead to infection, stones, synthetic underwear. So all these are very important for your teaching question. Remember, what is UTI is nosocomial infection. What is nosocomial? We develop in the hospital. So what do we prevent here? Patient from infection. So what do you do for your teaching questions are going to be, you are in a group of people, you're teaching to prevent UTI. These all are very good for your exam. Synthetic underwear, they must wear cotton. And also wet bathing suit can lead to sexual intercourse, one of the answers. Prevention, keep cleaning from front to back. Avoid bath, bubble bath, spray. And void and drink glass of water after the intercourse. If pregnant, void frequently. Avoid sitting and wet bathing suit, cotton panties, avoid tight clothing, or with the tight slack and the tight clothes. So UTI is important, we all should know. And what are the sign and symptom of UTI? We all know frequency. Patient goes to the bathroom or you go frequently, could be sign of UTI. Burning on urination, another sign. Pain in abdomen and cloudy color of urine. Color is not clear, very cloudy. Sometimes they use the word sediment, cloudy, dark. Foul smelling. Foul smelling is different than strong odor. If they have a strong odor and foul smelling, which is the sign of UTI? Foul smelling. Strong odor can be lack of fluid. Dark color can be lack of fluid. So remember the wording, foul smelling is not good, that's bad. Hematuria, sign of UTI, always sign of UTI. So remember, these are signs, burning, frequency, foul odor, and hematuria. And patient would feel fever, chill, nausea, vomiting. Older patient, all your sign of infection, altered orientation, level of consciousness. Write down the word confusion. Patient, older patient, they're very confused. They may not be able to say what would be the sign of infection, or maybe confusion word, maybe altered orientation word. What do you do intervention? Patient complains UTI. Number one, you do urine test, UA and CNS. Increase fluid, acidic urine, and discourage lot of irritants for the UTI, tea, coffee, cola, alcohol, very important for your teaching question. And medication are macrodentine, aminoglucosides. I want you to write down under aminoglucosides are, ending word are myosin. That's very important for this is myosin or sin. Garamycin. You're taking garamycin. Myosin is ending word. So remember, what is ending word? Myosin and sin. And these are strong antibiotic, and you're giving IV, maybe some IM. What do you monitor when you're giving is aminoglucoside? They may not use the word, but you should know all your mycin drugs are aminoglucosides. Now we need to know. In your question can be, patient is scheduled, a patient is taking garamycin. What is garamycin you monitor? I want you to write down the word nephrotoxicity. What is nephrotoxic? Means the kidney. What do you monitor in kidney? Your answer BUN and creatinine. They did not give you any word, any other word, and they say patient is taking garamycin, and they will give you the lab. And they will say, what do you report to the doctor? Remember, what would be high here? Creatinine. Next question can be ototoxicity. Ototoxicity means ear. You monitor for hearing test. What are we monitoring? Hearing test. Another thing is you do lab. In your lab, the blood test is called peak and trough. Remember the word peak means after your antibiotic dose. After antibiotic. Trough means before you are going to hang your antibiotic. Are we clear? Peak means after you finish antibiotic dose, maybe they will give third dose of antibiotic. So you hang antibiotic. After antibiotic is over, lab need to come in 30 minutes to draw the blood. Trough means before you are going to start antibiotic, you draw the blood. They are checking the blood test. What are they checking in the blood test? Is the level of the medication. Everyone is okay? What are the aminoglucosides are? Is ending word is syn or myosin. Are we clear? So you got to pick up. They're not going to say syn or myosin, but they will throw the wording garamycin. Patient is taking vancomycin. And they gave the lab, and doctor has ordered which lab are you going to notify. Remember, it damaging the kidney. They got to be careful. They got to check their level when they're giving, and they must check their BUN and creatinine, because if your creatinine is going high, that means the infection is clearing, but this drug is damaging the kidney. Are we okay, everyone? So this is one of the drugs everyone should know. Macrodentine, they can give for infection. Sulfonamides. I want you, whenever you're seeing the word sulfonamides, you increase fluid. Write down the word increase fluid, because you want all the sulfa. And also remember, check for sulfa allergies. Now, they're giving you a question, patient has UTI, you already know they might be giving macrodentine, maybe they're giving aminoglucoside, and maybe they're giving sulfonamides. Sulfonamides are antibiotic like sulfa drug. Are we clear? And what do you monitor when you're giving sulfa drugs are fluid, increased fluid. And what do you do after your antibiotic is over? What do you do after antibiotic is over? Is check their infection again. And what do you do? Culture. How do you know patient infection is clear? Another question. Patient is going home for 2 weeks antibiotic. What do you teach as a nurse for your patient? That follow-up appointment after they finish antibiotic, and you collect urine specimen, and what are you checking here? If infection is clear. Everyone is okay? You got to do follow-up appointment. So that covers your UTI question, and I want you to write down the common organism for UTI is E. coli. E. coli is most UTI caused by E. coli infection. Now I will move on, urosepsis. Now urosepsis is negative bacteria. Responsible, you do have in urosepsis, correct the spelling, urosepsis. Urosepsis comes from infection, E. coli. What does urosepsis mean? Septic infection. What is one of the reasons you can have urosepsis is, number one, from indwelling catheter. So whenever your patient has urosepsis, what is it leading patient here is septic shock. Remember, we have shock, same shock. Symptoms are shock are same. But how do you get patient is going into shock? Maybe sepsis. Sepsis is called septic shock. Patient has got bad infection all over in their blood. The sepsis is spread and leading the patient into what? Septic shock. So septic shock, what is one of the reason is here? Indwelling catheter. I'll tell you one example. Had a patient who had a catheter, and patient was start having fever, and patient has catheter, but nobody is looking if the catheter is draining or not, and they called the doctor ordered antibiotic, and fever didn't come down, and now next day patient is unresponsive. Why? Because patient is in shock. And what happened? The infection was all over. But we didn't get early. Patient goes to the hospital. and the doctor wants to check the urine specimen. There was no urine coming out. That means what? The catheter was blocked. And what happened later on when you collect the urine specimen? There was no urine specimen, the catheter was blocked. When they removed the catheter, what was coming out from the bladder was all pus. What does it mean? That catheter caused infection. And nobody knew the catheter is blocked. Your patient is running fever. Wouldn't you see first thing, let me check, where is the infection? Maybe in the bladder. None of the nurses has seen the patient has. And what was the another problem? Was nobody ever document when was the catheter changed. Big citation, big problem. So when we are nurses, change the Foley catheter. And it doesn't matter your treatment nurse. We all are together as a team. You have one who's doing treatment, you are a med nurse, but it's equal responsibility. We must know when did we change the Foley catheter. You must change them as needed basis, PRN basis, at least once a month. And most of the time patient pulls out, most of the time is blocked. So it's a good time you change the catheter. But when you change a catheter, do you have a doctor's order? Make sure you have doctor's order. Make sure you document in your catheter section, Foley catheter change PRN. Now I changed today. I'll put today's date, 6/24, and I'll document on the chart that I changed this catheter. If I don't document, even you changed it, it doesn't prove if anybody has changed the catheter. So what was the problem here? Catheter was not changed. Patient is running fever. None of the nurses has looked in the patient why he is running fever. Is the patient catheter is blocked or not? So what does the Foley catheter, if you do not maintain sterile technique, you do not change the catheter, you do not encourage fluid, what is the catheter is leading here to the patient to go into sepsis. Are we clear? What is another reason can be urosepsis is when the bladder, you're retaining prostate enlargement. Patient has prostate enlargement, patient is not able. I have seen a patient who had just started with a prostate problem and he went to the hospital because why? When he went to the doctor's office, his potassium level was very high. And they sent him to the hospital. Now they're not worried more potassium, not the urine, but he was going in a cardiogenic shock and septic shock. So what is the main thing? First thing, to lower the potassium level, stabilize the blood pressure, then you're worrying about the prostate gland. So when patient cannot pee, patient is retaining and bladder is retaining. That's why even your patient, they pee a little bit and they don't pee completely. What happened? They can go in a septic shock. What is septic shock? Is a bad condition. One of the reasons for septic shock is Foley catheter, retention of the urine. And what do we do in urosepsis? And one reason, remember the word E. coli, anytime, any question. What is one of the reasons to get UTI is E. coli. What do you do for your patient here? In the answer, culture. First thing, immediately, you got to remove the catheter and they got to do the culture. And culture, if there is a sepsis there, you got to give IV antibiotic, not oral. This infection is all over. How do you treat them? By giving IV antibiotic. So remember, IV antibiotic until a febrile, until the temperature is going down and stabilizing your patient. Now, I will move the word pyelonephritis. Remember, I said the word in the morning when we said IVP, pelvis of the kidney. So when they're giving you a question, patient has pyelonephritis. Immediately, pyelonephritis is different than UTI. Are we clear? Where is the UTI? It's starting here, but now where is the UTI is in the kidney. So kidney is getting damaged because of UTI. So pyelonephritis means where is the infection now? Kidneys. And what is the kidneys are? Upper UTI, lower UTI is bladder. So where would be the problem here? Renal pelvis, pelvis of the kidney. Underline the word acute, from infection, from following invasive procedure, or urinary tract infection. How infection? It started lower, but keep on getting infection or catheter, it goes up here in the kidney. Are we clear? So where does the infection is reaching now? To the kidney. See how you got to learn to read the question. Patient has UTI, lower abdominal, you're using the word cystitis is a bladder. Now your question is pyelonephritis. So where is the infection? Pelvis of the kidney. So inside the kidney. And what is the patient would be chronic pyelonephritis, could be also chronic stone or obstruction. Any obstruction, urine keep on going back in the kidney is leading what? Infection. Are we clear? So patient cannot pee, patient has retention, patient has bacteria. Sign of pyelonephritis would be the pain. Where is the pain? In the kidney, in the back. So underline the word affected side or flank area. And cloudy urine, foul smelling urine. Increasing the infection is bad is white blood count, maybe in the urine, white blood count in the blood, and you will do the CBC. White blood count is sign of infection. Fever, chill, frequency, urgency of the urine. What is the main thing I said here? Affecting what? The back pain, a lot of back pain. That means your kidneys. Next page, chronic pyelonephritis. Keep on getting. Kidneys are going to get bad. And what does it lead to? Underline the word renal failure. Everyone remember the word pyelonephritis question when you're doing. Look into it's in the kidney. Patient has pain in the back. Sign could be fever, chill, white blood count, pain is there. And when you keep on getting pyelonephritis, lead to renal failure. How do you know for the renal failure? Underline 3 wording at the end. First thing, any question, proteinuria protein is in the urine. That means kidneys are bad. You never have protein. Number 2, pyuria, pus, and azotemia. Azotemia word, nitrogen-based is high. What is nitrogen-based are high here? BUN and creatinine. So everyone, pyelonephritis lead to what? Renal failure. What is sign of renal failure? Proteinuria word, azotemia word, all this renal failure. What do you do? Intervention. Kidneys are bad. Now, if they start infection, yes, it's okay. When you don't have renal failure, you give fluids because there's infection, fever, and monitor for dehydration and low protein. If they're getting bad, protein may need to cut down. You can give warm bath, warm soap for the pain, and monitor for renal failure. Polycystic kidney disease. What is in polycystic kidney disease? Are cyst formation. Cysts are inside the kidney. Underline the word hypertrophy. What is the kidneys are? Hypertrophy. Kidneys are getting big. Why? Because they have multiple cysts inside the kidney. So what is the cystic disease? Is polycystic. Lot of cysts are inside the kidney. And underline the word, they can rupture and they can damage, and all these cysts. Now remember, you have nephron word, you have is also little nephrons inside the kidney, and that's important for kidney function, and nephrons can damage. So cyst can damage the kidneys. Ultimate result with renal failure. So what are you monitoring? For pyelonephritis, renal failure. Polycystic, what are you monitoring? Renal failure. And what is polycystic means? Cysts are inside the kidney. Then you will go, is data collection. A lot of time people don't know they have polycystic by age 30 or 40, and when you start going to the doctor and they see some changes, or they will do ultrasound, they will find out they have polycystic. And patients start feeling pain, flank pain, abdominal pain. It gets worse with the activity and relieves when they are laying. So there is a lot of pain. But patient doesn't feel they have the cyst until the later age. It can lead to hematuria, proteinuria, sign of kidneys are getting bad, pyuria, and may lead to also the kidney stone. In the intervention, gross hematuria means sign of cyst has been ruptured. Cyst rupture, they can have bleeding. In your teaching question, very important this line. They must take enough sodium and water, because sodium losing rather than retention because of the fluid. So they must take their salt and fluid regularly. Very important in your teaching is control their blood pressure, and if they're diabetic, monitor for blood sugar. So at their diabetes, and also monitor, because they may turn into diabetic. You don't want the kidneys to get worse because of blood pressure and sugar. And what would it lead to? What does lead to? Renal failure. And what do you encourage them? Genetic counseling. It runs in the family. Are we clear? So polycystic disease is genetic disease. That is number one answer. Number two, remember, you have cyst inside the kidney and they can rupture. There's no really treatment. It will form itself. It keep building and building, and they can damage the, so what happened? They take over inside the kidney and the cysts are damaging the kidney. Patient is going into renal failure. And it runs in genetic, and what do you teach them? Control your blood pressure. Follow-up appointment. They're going to do the ultrasound to see how bad the cysts are. So this is your teaching question. So everyone is okay, pyelonephritis lead to renal failure, cystic disease lead to renal failure. What are we controlling here for renal failure? The blood pressure and diabetes. Next is, I will move on, hydro. When you see the word hydro, means the fluid is retaining in the kidney. Hydronephrosis. Underline the word distension of renal pelvis and calluses. Now calluses is also in the kidney, and they filled up with the urine. And why? Because obstruction. Now we remember in how many kidneys we have. We have 2 kidneys. We have 2 ureters. So what happens if the urine is not draining? For some reason there is obstruction. So if we have here 2 kidneys, and you have the ureter, and this is the bladder. So what happened here? The urine is not flowing. Urine has problem here. Is going back in the kidney, and the kidneys are filling up of it, back up the urine. So what is hydronephrosis? Is distension of the fluid and where in the pelvis of the kidney. Maybe the ureter has damage. Maybe there is a bad situation. Maybe there's a stone. But what can it lead to? Urine is not going down in the bladder. Where is the urine is going? Back in the kidney. Are we clear? What is hydronephrosis word is? Remember the word urine is going back. The word is called distension of urine or renal pelvises. What does it cause? Pain. They have a lot of bad pain because the urine is going back. Where? In the back and radiating to the ground. Severe back pain, urine output will be very low, and patient would be blood pressure you need to monitor. And what do you monitor? Fluids, because they are retaining fluids. And when they remove the obstruction, then you monitor dehydration. So what happened? All of a sudden, you remove the obstruction, the fluid start draining, and they can go in dehydration. So all of a sudden, removing the fluid can lead to dehydration. Now, if they cannot remove the obstruction, so monitor for dehydration and monitor for diuresis and monitor for weight. And the last line is nephrostomy 2. Now what happened? Patients' ureter are bad and this urine cannot drain here. And what do they have to do? They may have to put the catheter directly in the kidney. Are we clear? And what do they do? The word is called nephrostomy. So what is the treatment maybe if they could not open the obstruction? Nephrostomy 2. And I want you to write down nephrostomy 2 is done surgically only in the hospital and only done by the physician. You cannot change nephrostomy 2. And very important, I want you to remember a sterile technique. And keep the urine bag, very small bag, because below the level. Now, if you put the bag on the stomach, the urine will go back. Are we clear? So what do you prevent in nephrostomy question? Never pick up irrigation, never pick up answer to change the tube because tube is changed by the doctor. And what do you prevent the patient from? Infection. Everyone is okay. So what is nephrostomy is? The tube is put it in to drain the urine. Now some people, if the ureter, they cannot do any repair, they may have to live with the nephrostomy tube. Are we clear? Why? Because there's no way the urine is draining. So where you are draining from the bladder, but we have two ureter which take the urine in the bladder, but now ureter are no longer functioning or there's obstruction, there may be a damage, and patient may have to live with what here? With the nephrostomy tube. Very serious is infection. Are we clear? Yes.
But still, the other kidney and ureter work, so.
Yeah, if the kidneys and if there is some obstruction and they remove, then the kidney urine can be emptied. But for some reason, if they don't have and the both ureter are bad, they will put in the ureter tube. Wherever the obstruction, one kidney, they'll put that, and patient has urostomy. The meaning of urostomy is the tube directly placed in the kidney. Okay. Next word, renal stone question. Renal stone wherever in the urinary tract. Urolithiasis means urinary calculi in the ureter. Nephro means in the kidney. Everyone should know calcium. Why you have high calcium can lead to stone. You are eating too much of calcium food, milk, and more, and can be a different kind of stone, oxalic, purine stone, and dehydration. What are the reasons for your stones are? Number one, calcium, too much of calcium you're taking. Number two, whether you're eating calcium food too much or you're taking calcium drug too much of calcium pills can lead to obstruction. Number two, dehydration. When you're giving diuretics can lead to immobilization, hyperparathyroid, and gout patient, and uric acid they have, and family history. Very important. How to prevent the stone. These are your answers. Next page we are going to move on, is data collection. Renal stone, pain patient has lumbar area, and ureter colic pain, they have genital area. And what do you monitor when you have renal stone? Highlight the word UTI. Highlight the word hematuria. Hematuria is a sign of UTI, sign of renal stone. Frequency and retention. Intervention. What do you do? Your patient has renal stone. IV, vital sign, INO, and underline the word increased fluid, either PO or IV. Analgesic for pain. They have a lot of pain. Give the pain medication. Ambulation is good, and turn frequently. And at there, filter the urine. All your stone, you must filter the urine and these other answers. Alkaline ash diet you will give for patient. These two diets are important for knowing when patient has pain. Alkaline ash diet, I want you to write down the word gout. Which patient do you give them in gout? And what do you not give them, except you can give milk, you can give meat, only you will not give acid food, such as cranberry, plums, and prune. So what are you not giving? Cranberry, plums, and prune. What are we cutting down here? Acid. Go third line. Increasing the pH, but what are you decreasing here? Acidity. That is alkaline. And which patient you will give gout. And second, acid ash. I want you to write down which patient you will give acid diet. Calcium phosphate. When you have calcium stone, they have calcium phosphate stone or calcium oxalate stone. So write down those, calcium stone. And what would you give here? Here you can give everything. That means you can give acidity and underline cranberry, prunes, and plums. That is the difference. Acid ash, you can increase acidity, meat, fish, everything is okay. But remember, here you are increasing cranberry, plums, and prune. Increasing the pH and making it more acidic. That's the difference. Everyone remember, in your NCLEX, you got to know the diet. Acid ash, alkaline ash diet goes in the stone. Now, if you have a stone, what is another treatment is ESWL, which is called extracorporeal shock wave, or sometimes they only give the word lithotripsy. So everyone should know, when you see the word lithotripsy, you're removing the stone. Underline the word is non-invasive. It's not invasive procedure. Underline the word no incision. And what is an invasive procedure? First line, breaking up the stone. So this treatment is non-invasive, number one. Number two, remember, we are breaking up the stone. No incision, third line. Fourth line, they can visualize by fluoroscopy and underline the word ultrasonic waves. They're giving ultrasonic waves. And they're is disintegrating. That means they're breaking the stone and urine within a few days. Pre-op care, NPO, post-op care, vital sign, hypotension, tachycardia, and monitor for bleeding. Second line, hematuria is normal. And they can ask you in the exam, hematuria is normal. Fluid you increase. Ambulation you increase for your patient. Next page, percutaneous lithotripsy means it's invasive. Underline that word. Percutaneous means invasive. In the first line, they are performing to remove the stone from the bladder. Invasive procedure, underline guided wire. They are introducing and aiming to the stone, and ultrasonic wave, they're breaking it down. So when they're using the word cutaneously, they're using the wire and they're putting through the skin. It's called invasive procedure. Percutaneous can be lithotripsy and maybe nephroscopy. Lithotripsy means no incision, and small incision is only given when they're going for nephroscopy. What do you do here? Encourage fluid. What do you monitor afterwards? Complication. This one, bleeding, is complication. Now, ureterolithotomy, when they're removing the stone from the ureter. Pyelolithotomy means from the renal pelvis they're removing. Nephrolithotomy means from the kidney. Nephrostomy means is the tube, they put it in the kidney, which we already talked about it, and nephrostomy tube, and they have a drainage bag and prevent infection. Another infection in here, you all need to know epididymitis is in the male. And underline the word in the first line, caused by UTI, very important, STD, sexually transmitted disease, or prostatitis. If patient has prostatitis, it leads to infection. Second line, it can cause infection and go up, but first line, very important, that we must know sexually transmitted disease and prostatitis. What is the main problem with the patient? Data collection, scrotal pain, they have a lot of pain, and pus and bacteria in the urine, and they have fever and chill. So number one, everyone remember it's infection, so there is a pain, fever patient has, but scrotal pain is important to know. In teaching question, and they love to give sexually transmitted disease in exam, bed rest is important. Elevation of the scrotal area. Second line, cold compress. Third line, antibiotic for sexual partner. Next line, avoid lifting and straining. Last two lines are important in teaching. Limit the force of stream when they're peeing. Limit slowly. Why? Because if they force it, the infection can go up. And the last line, using condom to prevent infection. So sexually transmitted disease, scrotal pain is important. Prostatitis is infection of the prostate gland. And prostatitis, prostate gland, and data collection. Data collection, bacterial one, there are two, bacterial, abacterial. Bacterial one has infection, underline that, and when you have infection, they have fever, chill, and blood cells is high. What do you do intervention in prostatitis question? Fluid is good, sitz bath for pain. Second line is important. Draining the prostate is from the draining the fluid, such as intercourse, masturbation, and massage. Avoid, lot of question, avoid spicy food, such as is coffee, alcohol, also you avoid. And a ride, going prolonged ride because of pain. Sexual intercourse during an acute inflammation. So these are all your teaching questions are, is number 3 is important, line 3, draining by massage, avoid spicy food, avoid coffee and alcohol, and also sexual intercourse during acute inflammation, not to be. Next is BPH. What is BPH? Is prostate enlargement, benign. Third line, very common at age 50. What is the prostate gland? Around the urethra. Everyone should know it gets bigger, and the problem with the patient are they can pee. Data collection, very important. What are the signs of prostate enlargement? Starting urination. They have problem in starting, and decreasing the force of the urine. That means it's coming very slowly. So starting urine and decreasing the volume. The urine is not coming out enough. Second line, nocturia. What do you monitor patient here? UTI, urinary retention, distension, dribbling, and add their sepsis. Can lead to sepsis. If they cannot pass the urine, it can lead to bad infection. Intervention. What is the intervention are? Number 1, catheter. Now everyone should know what kind of catheter you will put it in when they have prostate gland. It's a special catheter, and it's called, anybody remember? Good catheter. Write down the word COUDE, Couch catheter. The problem here is the tip. If you will see, you guys have adult health nursing book, you guys have the picture. And this is the one in the bottom, the front part of the tube is going up like this, not the straight. So that is called the Coude catheter. So what kind of catheter you are putting it in? COUDE, and the front part is tip and pointed. Are we clear? So everyone should write down that wording. And what test do you do here for prostate enlargement? Blood test PSA, prostatic specific antigen. This is a blood test. And second, rectal exam. Rectal exam is important, and PSA test is important to do here. And when you're looking, what is a normal PSA? 4. PSA test 4 ng. Write down 4 is normal, and that's 4 ng per ml. And medication. What medication you will give them for them? They can give them some of the drugs to help them to urinate. And those 2 drugs are, you have the drug package here. On the first page, if you will open your drug package, on first page, you have in the bottom, it says Proscar. Proscar, in the bottom, it says testosterone and Proscar. And I want you to add there Hytrin, Hytrin, Hytrin. And you have the second one, which is you have already, is Proscar. These are the drugs are given to help them to empty the bladder. Now, all these on the top, you have some of the other drugs for UTI, pyridium, furodentin, but I want to finish the package here first. So everyone should know 2 drugs are, is Proscar, you also have here herbal therapy, and you also have Hytrin in the thing. Surgery treatment is done, is called TURP. What is TURP is they're removing the prostate gland. Next page, complication of TURP. I want you to highlight the word bleeding. And what do you, the doctor will order here, write down the word continuous bladder irrigation. And what do you monitor for continuous bladder irrigation? I want you to write down the word water intoxication. So 2 things I want you to remember. TURP, they're removing prostate, you're monitoring bleeding. Underline the word hemorrhage, bright red, increasing viscosity, notify physician. Third line, dark urine, is to stop the bleeding. And what do you do? Underline the word apply traction. Underline that word, apply traction. And what do you tell the patient when we are applying traction? Keep the legs straight. Don't bend. And tape the catheter. That is for traction. You have another surgery is called suprapubic. Whereas suprapubic is, underline the word, midline incision in the abdomen. So where is suprapubic? Above the pubic area and lower part of the stomach. And how many catheters patient come back? Write down 2 catheters in suprapubic. One is coming from abdomen and other is Foley catheter. So patient come back 2 catheter. Everyone should know. Those 2 are very important for exam. And perineal prostatectomy. They can go from pelvic area and remove the prostate. Retroprostectomy, low abdominal incision. There are 4 types of surgery. 1 and 2, everyone should know. Suprapubic, when they come back, they're removing prostate gland, but the patient come back with 2 catheter. When they come back with TURP, how many catheter? They have 1. But what is the kind of catheter in first one? They have 3-way catheter. And what does the doctor order here is irrigation. Now, last one, bladder cancer. We all know sign of cancer is patient has painless hematuria. Symptom. Everyone should know the reason for cancer in the first line. Risk factor, smoking, and your chemicals, carcinogen, radiation, cholesterol diet, but very important, everyone should know smoking. And what does the patient complain here? Painless hematuria. Patient is admitted, patient says, I'm having painless hematuria. Don't look for UTI, sign of cancer. What do you do here? Tell the patient to see the doctor as soon as possible because you want to make the diagnosis. And what do you do is the last thing I want to say, surgery, urinary diversion. Now remember, what is the bladder does? So we have two kidneys here, and then what do we have here? The ureter and the bladder. Now bladder has the cancer. What do? They got to remove the bladder, and what will they do? They will take the ureter, and where are they going to do? Attach to the cutaneous wall, to the skin, coming out to the skin. Maybe they can attach to the intestine and the urine and ileal conduit. That means these are the surgery. Ileal conduit word is they have a bag and they put it inside the abdomen where the urine will collect, and then you will take a catheter and empty the bladder. So remember, bladder, urine is not going in the bladder. If they remove it, the urine has to come out through the skin cutaneously. So the bladder removed it. What is the purpose? Bladder was like a bag, and we are emptying the urine. Now patient has a cancer and the bladder may need to be removed. Then what will happen to the urine? They got to divert the urine. Just like you have colostomy, you can have urostomy, but different surgery. Maybe they're going through the ileal area, the urostomy, sigmoid scopy mean they may be going to the sigmoid area and they're diverting the urine. So remember, they have to do the surgery just like the BM is coming out, the urine has to come out through the different area. The last thing I gave you guys is this package, just I want to show you, is this package has a lot of other drugs, but first page you have furodentin, is your antibiotic. Pyridium is your pain. When a lot of patient has pain, pyridium, in the third box it says analgesic, to relieve pain. And next medication you have ditropin, probenthine, and I want you to add detrol, D-E-T, detrol. That is for also given for your patient for anticholinergic medication. And reducing the bladder spasm and treating urinary incontinence. The next box you have Viagra, that is for erection. And the last box we said about the prostate enlargement. Second page you have also the drug which are called anticholinergic. I want you to start looking the drugs as you're moving on probenthine. When you're giving probenthine, it decreases the vagus nerve, and monitor, you give them before meal. Belladonna, for pain, you can give them. Atropine sulfate is anticholinergic medication. Now you do have some more antibiotic, is antifungal, you have on the next page. Then you have another INH-TB medication, viral, but these 2 pages goes with your urinary system, okay? So I'll stop here. You guys, we have done the total urinary system, okay?